Thank, thank you, everybody. Thank you, Dr. Neglia. It's a privilege for me to open the grand rounds today by introducing Dr. Christina Boull, who is my partner and colleague. Dr. Boull is Assistant Professor of Dermatology and Pediatrics here at the University of Minnesota. Christina was our inaugural fellow in 2015, and now she's our fellowship director. She brings a wide range of medical expertise to our team because she is quadruple boarded in medicine, pediatrics, dermatology, and pediatric dermatology. Christina has gained a lot of national recognition for her clinical and research expertise in the area of cutaneous reactions to targeted chemotherapies, as well as genetic skin disease. She helps our division address that important unmet need of transition of care from young adults graduating from pediatric dermatology clinic. Dr. Boull is very active. She sits on the executive committee for the American Academy of Pediatrics section on derm, as well as the Council for Pediatric Subspecialties. She's a sought-after speaker, award-winning teacher, and mentor in our program, and we're so fortunate to have her. She's going to be speaking today on recognizing skin disease in skin of color and why we don't. Thanks, Christina.
Thank you so much, Sheila, and thank you for joining me this morning from our Discovery Clinic. So welcome. My disclosures before I start, I do obtain consulting fees from Alexion Pharmaceuticals, but I won't be talking about off-label drug use today. So my goals today are to talk about recognizing a problem. And let me just start, off the bat by saying that it is not lost on me that I, a very Caucasian female, am even giving a talk on this topic, which perhaps in and of itself speaks to a more system-wide issue with diversity within our specialty. But please know, however, that this is a topic that I care deeply about. It first came to my attention when I became the director of our advanced dermatology course, which is a pipeline to dermatology residency. And so I hope today that by the time I finish this talk, you'll share just at least some recognition of this problem with me and ways to address it. I'm going to talk a little bit about why we struggle to recognize skin disease and skin of color, review just a few examples, and then provide some resources that are point of care that you can use in clinic to help. I want to start to wake everybody up with a photo quiz, and I'll provide some reassurance that there are no zebras here. So all of these diagnoses are some of the most common that we might see in primary care clinic. And instead of answering in the chat right now, if you just want to think to yourself what the diagnosis is, we'll talk about it a little bit more later. I'm going to start with a case of a 5-year-old male presenting with this bump on his arm. And it's been present for about 3 days, seems to be getting a bit bigger. There's no associated pain or itch, no known trauma. He does like playing outside. So I'll have you think about what your diagnosis would be if you were seeing him. Our next child is a 15-month-old female, and she comes to see you for a rash. This has been present, her mom says, for about 2 months, and some days it looks better and some days it looks worse. It is pretty itchy. She sometimes is waking up at night itching. How would you treat this? What would you recommend for the family? This is a 12-year-old male, and he is bothered by these dark bumps that are coming up. They've all come up pretty rapidly over the course of the last week, kind of focusing on the face, the neck, the creases in the armpits and in the groin. They're a little bit itchy, but not super bothersome in that regard. He otherwise feels well and has been feeling well. No one else at home has similar rash. What is your diagnosis? The 7-year-old male, and he's coming to see you for these spots on his face. And they don't bother him a ton, but they do worry his mom and dad. They've been present for about 2 months, and he's getting more. And they really show up in the summer. So starting around like this time of year and then getting progressively more noticeable. They sometimes get scaly, but not always. He does have a history of some seasonal allergies, but he's otherwise been healthy. What is your diagnosis and how would you think about treating this? Okay. And then finally, we have a 12-year-old female, and she's got this acute onset rash. And this has been pretty itchy for her. She woke up with it. She recently was sick with like an upper respiratory type symptoms, rhinorrhea, cough. Okay. So if you think about a diagnosis, all right. And I'll review the answers as we go through the rest of the talk. So if that felt really challenging, you are not alone. There was a study looking at about, over 200 medical students during their clinical years. So in their third and fourth year of medical school. And they were asked to identify photos of common skin conditions in both patients with light skin and skin of color. And across the board, they struggled a little bit with this, but you can see that there was a significant discrepancy in their ability to discern these pretty common rashes and lesions in skin of color versus more pigmented skin, particularly for things like, squamous cell carcinoma, where even only 50% were able to diagnose this in lightly colored skin, but 10% in skin of color. But most conditions, they were more readily able to diagnose in more lightly pigmented skin. There were a few conditions that they were more likely to be able to diagnose in skin of color. And you'll notice that was tinea versicolor, tinea corporis, bruca vulgaris, and psoriasis. And so we ask, why the discrepancy? Why are students so much better at being able to see skin disease in lightly pigmented skin as opposed to darker skin tones? And there are lots of different reasons that have been identified, but one major problem is our training tools. When we look at medical student study materials, there was an analysis of the 4 most common board study books for step 1 and step 2. And so 4 references were analyzed, and they contained a total of over 500 clinical images. And only a quarter of the images actually depicted skin disease in skin of color. When we look at other references across the board, we see that this is not unique to med student study materials. So in our general medicine textbooks, only about 4.5% of images show skin disease and darker skin tones. And in our core dermatology textbooks, only between 4 and mostly 10% of images with an outlier of 19% show skin disease and skin of color. And, for those of you who've done a dermatology rotation and come to some of our lectures, that this is a core principle of teaching would be pattern recognition and repetition. And so if our trainees are not seeing lots of pictures of skin of color with different skin conditions, we're not going to be able to recognize this as well. And when we look at what conditions are depicted, it's the same few. So we would see more pictures of tinea infections, and you'll remember that the tinea infections were some of the skin conditions that our med students were better able to identify in skin of color, lichen planus and vitiligo. So then we go back to the root of this problem. Why are there so few images of skin disease and skin of color? And we know that in general, there's less access to dermatology for patients with skin of color. And then depending on the skin disease, some people would say, well, it's easier to see certain skin diseases in lighter colored skin versus darker colored skin. So for instance, this is a picture of vitiligo on the wrist of a fairly pigmented person in the top, and then in a more deeply pigmented person on the bottom. And you might argue that it is easier to see the classic characteristics in more darkly pigmented skin in vitiligo, and some other conditions more easily in lighter colored skin. Okay. But unfortunately, we have some real consequences from this problem. So first of all, we have low diversity in dermatology training and even across dermatology in general. So we are one of the least diverse specialties. And I think that, there's lots of different things that feed into this problem. First of all, mentorship. So for our students, when they look around at the derm departments across this country and don't see people who perhaps look like them, they may not think of dermatology as a specialty that would be welcoming. Also, dermatology, there's a perception that kind of on day one of medical school, you need to decide if you want to pursue dermatology. And so some of our students who don't perhaps have that background of medicine in their family may not know that, or may not know how to pursue that, or may not have an inside track on those opportunities. We also know that people with skin of color are half as likely as white patients to see a dermatologist for the same condition. Again, this goes back to trust and representation, wanting to see a doctor who you feel like can understand you, who perhaps looks like you. And then we have inaccurate or misdiagnoses. And this, again, goes back to our training. So lack of awareness on the part of physicians, as well as lack of training and what different skin diseases look like in darker skin tones. And then finally, we have inequity in treatment as well as survival. And I'll talk a little bit more about that. Again, concerns about access to specialty care as well as clinical trials. And this is a growing problem. So right now we have patients with skin of color comprising the majority of patients in certain states, but by 2042, more than half of the US population will have skin of color. Okay. In thinking about, well, what are some of the consequences as far as our treatment inequities? We have a good study looking at over 30,000 patients seen specifically in clinic for acne. And this study showed that Black patients were less likely than white patients to actually be prescribed medication during that visit, and also less likely to receive some of our more powerful systemic agents than white patients coming into clinic. Okay. We think about health outcomes, specifically for melanoma, our most deadly form of skin cancer. There is a 2 to 3-fold greater risk of mortality among Black patients with melanoma compared to white patients. And some of the things that have been postulated about why this is true is lack of awareness. So perhaps physicians not thinking to do a skin check on our more darkly pigmented patients, thinking that skin cancer just doesn't happen. We talked about low or delayed access to specialty care. And then we do know that melanoma in our more deeply pigmented patients tends to come up on less sun-exposed sites and more sun-protected sites. So there may be something different about the genetics or biology of the type of melanomas that form in our patients with skin of color. And if we have low data on those patients from clinical trials due to lack of participation or recruitment, we just may not know how best to treat individuals with these types of melanomas. In research, when we look at clinical trials, and this is likely true in a variety of specialties, we compare randomized clinical trials for the treatment specifically of our most common skin diagnoses and look at the percentage of trials that actually report the race or ethnicity of the recruited patients. We see that even though between 2010 and 2015 to 2020, there's been an increase in the number of trials reporting this number, that number has actually stayed the same. So the percentage of clinical skin trials with more than 20% non-white participants was unchanged at 38%. And so even though we've been aware of this issue in research, we really haven't been able to move this number. And again, even though we're aware of this, we're not seeing improvement in other aspects of reporting either. There was a systematic review in 2020 evaluating articles on the cutaneous manifestations of COVID. And there were 130 clinical images published total. And of those, 120 were from individuals with the most lightly pigmented skin. So in dermatology, we often use the Fitzpatrick scale, with the lower numbers being the lighter pigmented skin that tends to burn and not tan, and the higher numbers being more deeply pigmented skin that tends to tan. And there were no images of patients with skin types 5 or 6 or more deeply pigmented patients. And this was very recent. So I've outlined some of the problems, but what can we do about it? So I think the first step is, of course, recognizing the problem and thinking about our own training, reevaluating the training materials that we had, and finding a way to be good self-learners, to improve our understanding of the manifestations of skin disease and skin of color. From the bottom up, we have to think about mentorship and recruitment, particularly in our specialty in dermatology. A lot of programs across the country are introducing something similar to what we've started here, which is the Health Equity Award, where we are offering a stipend to visiting students to offset the expense of their stay with us. So housing expenses and transportation for a month while they do our away rotation. And we're offering this to students who have demonstrated strengths in research into health equity or volunteerism in health equity. The other thing that's really important is early mentorship, and I'll give some resources for that. And finally, wanting to support the individuals as well as organizations that are really addressing this problem at the root causes. So I think a great resource for our medical students would be the Skin of Color Society. And this is just a screenshot of their webpage. This is a society devoted to improving outcomes for patients with skin of color, but also recruiting more people with skin of color into dermatology. And there are lots of different resources on this webpage for both mentorship locally and across the United States, and also different scholarship opportunities, research awards. So if you are a student who is interested in this topic, this is certainly something I would check out. I'm going to talk a little bit about visual DX, and I think this is most important for the learners in the room. So visual DX is a resource available to all of us through the biomedical library. And when you log in, you are able to actually build a differential based on category. So for us, we're looking at dermatology, and you can see this is broken down into dermatology of all skin types and dermatology of skin of color. And I'll do a little demonstration of this in a minute. They have taken on this problem wholeheartedly through their project impact. And so they comment that they feel like healthcare providers who evaluate the skin should be able to recognize skin disease in all skin tones. They understand that part of the problem is our training tools and the resources that we're using for learning. And so they want to use their platform to help us expand our differentials for patients who do have more deeply pigmented skin. Okay. I'm just going to show a few screenshots of this so that people who haven't used this before can understand better how it works. So if you log in and you say that you want to build a differential, you can choose the skin type of your patient, so dark skin versus light skin. And you can also comment on what the patient's age is, their gender, and then any other findings that you have on exam that could be helpful. So here you can choose the skin lesion type. I'm choosing scaly papular plaque. I imported that the patient has rash or multiple lesions of scaly plaques that are widespread. They have associated fever, but otherwise the patient appears well. And so once you import this information, you can click on build a differential, and it will pull up the things that match the best. And so it tells you what are the things to consider first, what are the less common diagnoses to consider second, what are the things you really don't want to miss, and then it further sorts these out based on infection and drug induced. And so if I looked at these pictures and said, yep, it looks like my patient probably has psoriasis, you can click on psoriasis, and then it gives you a little synopsis of psoriasis. And this particular article is psoriasis in children, talks a little bit about the pathophys as well as different considerations to think about psoriasis in children, treatment options, et cetera. So this is a really great tool. And even as a dermatologist, I use this not uncommonly in clinic. If I have someone coming to clinic, particularly for that second or third opinion, and the workup has been unrevealing, and I just need to really expand my differential, this is very helpful for me to do that. And something that's very quick and easy to use even during a clinic visit. Okay. The other slightly surprising resource that is well known to dermatologists but may not be universally recognized is the DermNet New Zealand. And so this is a free website available to all of us. And they just do a really great job showing excellent clinic pictures, giving good point of care synopses for diagnosis and treatment. And they have really been committed to expanding their skin of color photo bank, as well as other descriptions of how diseases of the skin are different in skin of color too. So just another quick thing to be able to pull up in clinic. Okay. Finally, a great resource when you want to provide something for families would be our patient handouts at the Society for Pediatric Dermatology. These are also free. And you would just log on to the Society for Peds Derm webpage and then go to For Patients and Families and then patient handouts. And there is a whole variety of handouts written by pediatric dermatologists on here with, really great information. They're written at the family level. And the one that I just have pulled in here would be hair care for patients with curly or coily hair. And this is something that we frequently get asked about in our Peds Derm clinic. So a great resource as well. Okay. And then, I mentioned that it's important to work on boosting our own knowledge, knowing that many of us have trained in a time when there weren't really great clinical images of patients of skin of color. I think it's just important to recognize that skin disease looks different depending on skin tone. There are truly structural differences in the skin based on genetics as well as skin tone. And so our even really common skin diseases can vary in their clinical appearance. So the things that differ most often would be color, texture. So we see different textures of the same skin rash depending on skin tone, and also distribution. And while I can't give, a whole rundown of every skin disease and how it differs based on skin tone, I just want to share a few examples today. Okay. So the most common difference is, of course, color and, the color red. So our trainees, as well as even some of our more seasoned dermatologists who practice primarily with Caucasian patients, may have a really challenging time recognizing the color red. And this results in undertreatment of our patients who have, diffusely inflamed skin. And I think this picture is a good example. Both children shown here have widespread erythematous patches covering basically their entire legs. And if we were to see the rest of their body, they may well be erythrodermic. But for most people, it's easier to see that the child on the right with the more lightly colored skin just has diffusely red skin. So there are some tips that, we talk about with our trainees when, the color of the skin is in question as far as erythema. We have a few ways to sort this out. So one way would be, like in this picture, looking at less pigmented areas of the body. So the soles of the feet, for instance, and the shawl with the darker skin tone. And in peds, we're very lucky because we have a very easy way to discern, if the skin color is not at baseline, and that's by asking the family. So there are times when I ask mom and dad, I'm like, I feel like his skin is looking a little pink. Would you agree? And they are very quick to say, oh yeah, this is not normal. This is not his normal skin tone. And so that is another way that, if in question, we can sort out, our eyes really seeing what we think they are. So this goes back to our first clinical image of this 5-year-old male with a bump on the arm. And again, this is the child where this has been present for a few days and it's getting bigger. And if anyone wants to type in the chat, any ideas about a diagnosis here? I'm not seeing any brave souls, so I will show this image. Okay. Yeah. And maybe now people are starting to recognize what's going on. Okay. So we see a child with the same rash with more lightly pigmented skin. And we can see that bullseye more easily there. Okay. Yeah. So Lyme. So unfortunately, we have a higher percentage of patients with darker skin tones that are diagnosed with late stage Lyme and a lower number presenting with early Lyme. And I think a lot of this is just recognition. So this is a child with Lyme, and we can see both areas that look more targetoid, but also confluent indurated erythematous plaques. Yeah. And so with Lyme, our early localized Lyme, which is the time when we want to catch it, happens days to weeks after the bite in most people. And the redness expands outward and sometimes has a central clearing. Something to know about children is that it may just look diffusely erythematous. They're less likely than adults to have that true bullseye pattern. And they're usually asymptomatic, and most of the time they do not recall a tick bite. So in the season for Lyme, like starting now, it is something that I'd ask you to think about so we don't miss this and so it doesn't progress to late stage. Okay. So a similar situation where we have a 12-year-old female with this acute onset rash that is itchy. And if anyone wants to put a diagnosis in the chat, she has recently been sick with respiratory infection type symptoms. Okay. Yeah. So yes, Larissa, you are on target today. So she does have hives. And this is the same type of challenge where we might not see that really bright erythema that we see in white patients, but we do have the skin induration and swelling. Okay. So hives. So what we're looking for would be these really edematous wheals, and a way to help discern this, knowing that in darker skin, we might not appreciate that erythema as well, is actually looking for lighter coloration. So in the areas where there is the most edema, like the center of that wheal or hive, we see that it actually looks a little bit lighter. And then the pink is more at the periphery. In times when you're not really able to see what's going on, or you have a patient that's really itchy and the history sounds like hives, doing a little bit of cross-lighting with your otoscope, you might be able to appreciate this better than you could otherwise. In general, with hives, our lesions last less than 24 hours. And so we ask, if you were to circle one of these spots, would it move around or go away in that time period? A lot of the time people are worried about allergies in relationship to hives. We know the vast majority of acute hives in children are related to infection. So viral more than bacterial infections, as opposed to things like allergies or medications. And when we're seeing these children, typically we start some scheduled antihistamines at higher than normal doses for a stretch of time until the hives go away, and then wean them slowly. When we're talking about underappreciating the color pink and red in darker skin, I want to bring up acne, because this is something that is really disturbing to a lot of our teens. And we know that acne tends to be undertreated in our patients with skin of color. And so here we see photos of two teens who probably have similar severity of acne. So we see some small pustules, some, open and closed comedones going on. And in our lightly pigmented patient, we see more erythematous little macules, as opposed to a more deeply pigmented patient where we're seeing just more brown hyperpigmentation. And again, on the back. Okay. And so similar level of acne, but seeing hyperpigmentation in our darkly pigmented patient as opposed to the pink or red color in our Caucasian patient. So post-inflammatory hyperpigmentation. This can happen in our patients with skin of color with any kind of skin injury or inflammatory process, and so commonly acne. And this is due to a variety of culprits, so increased melanin production within the skin, and then leakage of that melanin into the surrounding tissue, and then uptake of our macrophages, melanophages, that are trying to take away this melanin, but actually deposit it a little bit deeper in the skin, making a grayish hue. And it is transient, but it can be really disturbing to our patients with post-inflammatory hyperpigmentation. And so I would say that when we're seeing these teens in our clinic, we always want to talk about treating the acne first, because the acne is what's causing the hyperpigmentation. But we do want to address the PIH because of the fact that, this is something that our patients may be coming to see us for primarily. So they may not realize that it's the acne causing it, or they're more bothered by the pigment than the acne itself. And something to think about that's a little bit different when we're trying to treat patients with PIH is being a little more gentle with the skin. And so our teens in general often feel like, acne is due to the fact that they're not cleaning their skin. They really want to scrub their skin. But unfortunately, the harsher products that they're using on these areas, the more likely they are to get more hyperpigmentation, and then can also induce an irritant dermatitis that can also result in hyperpigmentation. So just talking with our teens about using really mild products. You think about how can we help with the pigmentation and take this away a little bit faster. Our retinoids are a bonus in two ways. So they not only help treat and prevent our acne, but also can help to lighten the pigmentation. Azelaic acid is another agent that we might bring in just to really help more quickly clear the hyperpigmentation. Some of our patients may ask us for bleaching agents, and the most common that we would prescribe would be something called hydroquinone. This agent, though, also can be an irritant. And so in prescription strength of 4% or higher, we can see that it results in an irritant dermatitis in some patients, and then that also propagates the hyperpigmentation. Also, we know that inflammatory acne deposits pigment a little bit deeper, and so our bleaching agents may just not be as effective. So we want to just address the issue of bleaching agents and ask our patients to be really careful. There are some bleaching agents that are available, at specialty markets and things like that, that have a really high level of bleaching agent that can be harmful to use. And so just talking about these things and thinking about them together can be helpful and lead our patients in a safe direction of skincare. Finally, something that our patients who have more deeply pigmented skin may not think about is sun protection. So we use sun protection for a lot of different reasons. So to prevent photoaging, to prevent sunburns, but another great thing that it does is help minimize post-inflammatory hyperpigmentation. Some of our patients with more deeply pigmented skin may say, every time I wear sun protection, I look super pasty. I really don't want to wear sunscreen. One solution to that, there's a couple solutions, but one would be turning to our tinted sunscreen. So sunscreen that has a little bit of ferrous oxide in it, a little bit of a tint, makes the sunscreen appear, not that white pasty color. The other thing available would be sunscreen powders that are mineral based and more sheer. So all good options. Okay. The next patient that I want to talk about is this 7-year-old male. Came in with these white spots on his face. And I feel like we see this all the time in August in Minnesota. So our little patients who have these white blotches on their cheeks or on their arms or legs. And any idea about what's going on here? You can type it in the chat. Okay, that's a great guess. We have a tinea versicolor. Okay. And then, pityriasis alba. That's right. Correct. So the questions that we all will be asked when these kiddos come in to see us is this vitiligo? Is this ringworm? And did my topical steroid cause this? At least in derm, our families want to know these answers. And the answer to all of these questions is no. This is post-inflammatory hypopigmentation, and we call it pityriasis alba when it happens on the face, but it's the same kind of process in all areas. And again, anything that causes inflammation in our patients with a little deeper skin tone can cause hypopigmentation. And so common culprits are going to be psoriasis, atopic derm, sebderm, and then exogenous. I'll talk about that in a second. Well, this is caused by inhibition of melanin production or melanocyte disruption in the case of exogenous. Something our patients are always wondering about is this caused by the steroid use? And I think they ask that because of the fact that if their child comes in and they're covered in eczema and we do a topical steroid for them, they then develop these white patches all over. And the thing is that it was the inflammation itself that caused the hypopigmentation, but in their mind, attribute the light color to their use of the topical medicine. And then they Google this online and find blogs that say topical steroids are dangerous because they cause hypopigmentation, which just, tends not to be the case. And so just providing reassurance that it's not from the topical steroid use. So pityriasis elbow, we see this on the face, upper arms, and more commonly in the summer, because if the surrounding skin tans, these areas really don't. And so they become more prominent. As opposed to conditions like vitiligo, they are ill-defined. So in the child in the lower picture, it's really hard to see where the lesions start and stop. It would be hard if you took a pen to draw a perfect line around each of these. And they're not truly depigmented in the same way we would see vitiligo, that bone white depigmentation. They can be scaly because usually it's a low-level skin inflammation. So atopic derm, irritant derm that triggers this in the first place. So they may be scaly, but even if their skin gets hydrated and that scale goes away, the white spots may persist. And we tend to see this more commonly in our school-age kids. Okay. And so patients who have underlying atopic tendencies are more likely to develop this in dry skin. And in addition to our surrounding skin being more tan in the summer months, we can get irritation from sweat and swimming that makes this irritation cause more hypopigmentation. Our treatment for this is, of course, gentle skin cares. We want to use a nice thick emollient, and then consider a low potency topical steroid or calcineurin inhibitor, and that will help regain the pigment faster. And again, a situation where using sun protection can help minimize the discrepancy between the lighter and darker pigmented areas. Okay. Wanted to show an example of tinea and how this looks different. So in thinking about tinea, we have a scale, but it tends to be at the border with central clearing. And this could also certainly leave post-inflammatory hypopigmentation, but P. alba is much more common than tinea. And so here again, we see kind of the normal skin in the center with the raised scaly edge. Okay. And tinea is also much more well-defined. And then some pictures of segmental vitiligo in different skin tones. But again, seeing really this really bone white depigmentation, and then also depigmentation of hair structures within the patches. So we see in both eyebrows, we have loss of pigment. So looking for these other clinical clues can be helpful. Okay. Then finally, something to talk about would be exogenous depigmentation. So something that we worry about a lot in dermatology. This is a child who had been seen for treatment of warts with cryotherapy and had been depigmented from the liquid nitrogen. So just something to be aware of if you're treating warts in children with skin of color. Bleaching agents, again, we can see causing hypopigmentation or hyperpigmentation, something called ochronosis with high levels of bleaching agents. So another reason to avoid those in children specifically. Skin texture can be different in the same skin eruptions depending on skin tone. And this is just an example of that. So I have a 15-year-old or 15-month-old little toddler coming in with this rash, kind of up and down. It's been itchy. And so I'll take either diagnosis or treatment in the chat. Yeah. Yeah, so this is atopic dermatitis. Yeah, exactly. So in our patients with atopic dermatitis with darker skin tones, they are more likely to present with a papular morphology. So these little tiny bumps on the skin as opposed to our thicker scaly plaques. And sometimes this gets recognized as more just dry skin and so undertreated, and the child is still really itchy. So I would encourage you to think about atopic dermatitis if you're seeing a child like this who has these, really prominent little flesh-colored papules, and particularly on the trunk is the area where we see a more papular morphology, but then you can see some of these papules coalescing into plaques that are thicker. Okay. And of course, as a peds derm, I could give a whole lecture on the topic of atopic derm, But just in general, the things that we would recommend would be still are really great gentle skin cares. So we know that more frequent bathing is better for a child with dermatitis. So daily bath if possible with a mild cleanser, and then daily use of a thick emollient. So something hypoallergenic that comes in a jar, and then a topical steroid or calcineurin inhibitor, depending on the distribution and thickness of the dermatitis. Okay. These are just some other examples of eczema in more deeply pigmented children. And in children with skin of color, eczema may actually be more well demarcated, particularly in our children of Southeast Asian descent. It tends to be more likely on the extensor surfaces in more deeply pigmented children than in more lightly pigmented children. And again, more of that papular morphology. So we see this lichenification, this cobblestone pattern on the dorsal feet, and just these really more well demarcated plaques on the thigh in this other child. Okay. And then similarly, the texture in psoriasis can also be different. We see a lot more skin thickness. So really thicker plaques, hyperkeratotic plaques are more common in more deeply pigmented skin. And I just have an example of, again, the color. So in our lightly pigmented children and adults, we look for this really classic salmon pink color and these well demarcated scaling plaques. In children with darker skin, we see more of this silvery scale, and it can also be a bit more magenta. Okay. And finally, I want to talk about distribution. So the same rash can be in different areas depending on skin tone. And this is an example. So this is a tricky one. So we have a 12-year-old male with these dark bumps coming in that have had this rapid onset, really favoring the skin folds without other symptoms. Any guesses about this? So I'm going to show another picture. So this is pityriasis rosea. Good guess for tinea versicolor, but yeah, pityriasis rosea. So we can see in our patient with more lightly colored skin, our classic Christmas tree distribution, where the lesions are sort of going along relaxed skin tension lines. So kind of like this on the back, we see this salmon pink color again, little bit scaly, but in our patients with darker skin tones, we see some differences. So I was taught, well, it's not pityriasis rosea if it's on the face. It's not pityriasis rosea if it's in the folds. And that's just not true. So our patients with darker skin tones are more likely to have pityriasis rosea develop in just those locations, or, other locations plus those locations. So it looks really different, and also can be, again, more papular or just really hyperkeratotic. And so this is something that not uncommonly will get an urgent referral for in derm clinic, just because it is so impressive and it can look really different in skin of color. So again, just a review that typically we have a herald patch showing up, and that's more likely to happen on the trunk. And then, days to weeks later, these widespread scaling papules that tend to have this really fine scale over the surface along those relaxed skin tension lines. We think this is probably due to reactivation of herpes virus 6 and 7. And the color is so different. So this bright salmon pink again in our lightly pigmented patients, but more this brown silvery color in our more deeply pigmented patients. Again, looking in the skin fold areas can be another clue. May or may not itch. Usually lasts about 6 weeks, but I certainly have seen this last longer. Okay. All right. So in summary, I wanted to share with you today that there is a sizable knowledge gap in recognizing skin disease and skin of color, and there are real negative outcomes for that. Our health outcomes are worse in our patients with more deeply pigmented skin. And it's tricky. Skin disease can look different based on the color of the eruptions, the texture, as well as distribution. But it's still our responsibility as physicians who take care of all children with all skin tones to understand our own limitations and seek out resources to help us recognize these skin diseases. And so I hope I shared some of those with you today. So thank you so much. And I have a few minutes to take any questions.
I could ask you both questions all day long, and I do send you random questions. Since we have a little time, could you just talk a little bit more about papular eczema and how you approach it? Because I think I will admit my own, it's so diffuse often that I feel probably unnecessarily a little nervous about using a higher potency steroid over such a large body surface area, but they probably need some steroid. So like that picture you showed, what would be your initial treatment plan for that patient?
Yeah, so I think that, even within the same child, they may have different morphologies. And so more commonly, I might see classic plaque eczema in the flexural surfaces like the anacubes and popliteal fossa, and just this more papular distribution on the trunk. The good news is that papular eczema is pretty wimpy, so you don't have to go too strong to clear it. One of our frequent go-tos would be quarter strength triamcinolone, so triamcinolone 0.025 ointment. And that would be a great choice, or even you could start with a hydrocortisone 2.5% ointment. So even though you're using it over a broad surface area, we ask patients to treat all the affected areas twice a day until they're gone and continue just to target the active rash. And I would say within a few days, even though you may start out using a wider surface area for medicine, you're going to be treating smaller patches really soon. And so once you get them clear, it's easier to keep them clear. I think that the challenge is for kids who only partially clear with treatment, those are the ones that tend to flare right back up again, and you're kind of starting at square one. So just giving parents permission to say, or to use the medicine more widely until they, shrink down the rash, and then just targeting those areas. So again, a daily bath for these kids, a thick emollient, plain Vaseline is our best choice, or Aquaphor twice a day, mid to low potency topical steroid. Okay.
There's a number. Dr. McGinnis, do you want to help field questions? Want me to read them out? I'm happy to help.
I can definitely help. Christina, there's a question about limiting bathing versus more frequent bathing. I think you covered it, but if you could just review, because I think that's so important.
Yeah, this is something that has really changed, even in the last 5 years, I would say. But we used to think that more frequent bathing would result in skin dryness, and it certainly will if you don't use an emollient afterward. But this soak and smear technique is really great. So bathing just helps to get all of that stuff off the skin that is an irritant for eczema. So things like bacteria and sweat, and then helps the skin absorb some of that water. So we like bathing in a true bathtub where their skin is absorbing the water. And then as soon as they get out before the skin dries, just really, lathering them head to toe in a nice thick emollient. And this was just something that we had been observing in clinic as being beneficial, but there was a study that came out a year or two ago with kids with eczema that showed that truly more frequent bathing resulted in better outcomes for those kids. And then again, thinking about what soap they're using. So not wanting to use something that has a lot of plant materials or sudsing agents. And just because something is listed as natural doesn't mean that it's good for children with sensitive skin. A lot of those natural things, like I mentioned, contain plant materials that can both be irritants and allergens. So choosing something like a Cetaphil gentle cleanser or something without fragrance, like a sensitive Dove, things like that. It doesn't have to be expensive, but we do want it to be mild.
Thanks. That's so true. There is also a question about eczema herpeticum and how and when we would, consider admission for a child with eczema herpeticum. So maybe you can just touch a little bit on that.
Yeah, that's a great question. And so I think it just depends on the age of the child. Systemic symptoms and distribution would be the key things we're looking at So anything that's around the eyes, we of course want ophthalmology to weigh in on. There is risk of, viral meningitis with eczema herpeticum. And so if it is widespread in a small child and they're having systemic symptoms like fever, certainly we would admit them to start some IV acyclovir. They're immunosuppressed in any way, like we would see here at the U. Yes, they should come in to be treated. The other thing to remember about eczema herpeticum is even though it's caused by HSV, they usually have a bacterial secondary infection. So we want to treat both the viral infection as well as covering them for gram-positives with our antibiotic choice. So I think it's, your clinical judgment in addition to how widespread the lesions are. And if it's a baby or a toddler, I'm much more likely to suggest an admission as opposed to like an older child with just some eczema herpeticum on the arm or leg. And Sheila, what are your thoughts?
I think those are all, so important, great tips. I think bringing it back to skin of color too. I think eczema herpeticum might be picked up a little bit later in skin of color, before, because the erythema, before the lesions become vesicles, can, be masked by the pigment. So having a high index of suspicion, and please culture and send that, for the HSV PCR, that's so important. And you need to really get that swab in there and kind of make it bleed a little bit. It's not comfortable, but that's the way to get the best yield on your swab. So just a thought. I think as we close today, Christina, I just wanted to personally thank you for your work in this area. I think that because of things like what you've done with establishing our health equity grant and mentoring students through that opportunity, we're really, I think, starting to move the needle here with respect to diversity in dermatology, and we couldn't do it without the work that you're doing. So thank you so much.
Yeah, thanks, Sheila. And, we're of course not the only specialty that is really challenged with this, but I think it takes all of our attention to be able to work toward better equity in this area. And then it looks like we have just a couple more questions. Steroid-induced hypopigmentation, is it a myth? No, you can induce steroid hypopigmentation, but typically we would see steroid-induced atrophy prior to the hypopigmentation. And to get that, you really have to be using a decently strong steroid for long stretches of time on normal skin. And so even though this is something that families worry a lot about, maybe in all of, the patients I've ever seen, I may have actually seen it truly once or twice. And it was people who were using like clobetasol or really strong steroids on thin-skinned areas. So I would say probably 99% of the time, hypopigmentation is related to the primary process as opposed to the steroid use. And with the type of steroids that we're using in our babies, like hydrocort 2.5% or quarter strength triamcinolone, it would be really challenging to, even with frequent use, induce this. I am a colorblind person. I'm aware I don't see red in the skin. If color enhancing filters. And I just, Dr. Billington, I'm not sure of the answer to that. I would say that people who are colorblind, do actually work in dermatology. I am not as aware of what technologies are available, but but certainly that would be something that would be, worth looking into, or even writing, a little piece on how you as a person who's colorblind has been able to kind of compensate in other ways for areas of, not being able to see the color red as well. Okay. All right. So thank you so much for joining us today. And if there's other questions that come up, you can shoot me an Epic message or an email. Thank you.
Thank you,
Have
Christina.
a good Wednesday.
Yeah. See you, everyone.
Thanks everyone for being here. Bye.